Ma'am, we are live on YouTube.
Dr. Praful?
It's okay, but it appears as
We
it
are
is
live
zoomed
now.
out.
We are live now.
It's fine, but your this poster, no, it's looking very small. I don't know why. Full screen karo.
So it is on full screen. You can start.
Sunil, are we live now?
Sir, we are live. We are live.
So how many people have joined till now?
So we can see that in the participant section.
Okay, 41. So let's wait for 5 more minutes.
So, hello Puneet, Pallavi, Gunjan.
Good
to
evening,
see
sir.
our old experts back.
Hi, sir.
Hello, sir. Good evening.
So, good to see you guys.
Good evening, sir.
Hi, Pranita.
Okay, we are live now. So good evening all. Let me give a brief intro about this program that we have started under the aegis of DOS. Then our president will welcome you all. So this DOS PEP or postgraduate education program is a concept where we were doing 2 webinars per week, one on Monday, one on Thursday throughout the year. The idea is to cover the entire syllabus of DNB, diploma, MS, and postgraduate ophthalmology. And we have created a group. If you haven't joined, please join that group and give your feedback. So that will help us in refining our program further. So this is the first program of this series. And today, Dr. Gunjan is going to speak on eyelid anatomy, embryology, and congenital anomalies of eyelid. With this, I would request our President, Sir, Professor Rohit Saxena, Sir, to say a few words and welcome our coordinators and speaker for today. And then we'll move on with the session.
So, thank you everybody for coming. And this is part of the initiative of DOS to reach out to each and everyone all over the country, whether it's residents, general practitioners, and ophthalmologists who wish to upgrade their knowledge and their improve their practice. So this is the way we want to reach out to you multiple times a week. And there are a lot of physical events also planned. So whether it's physical or online, we are trying to reach out to you to solve your problems, to ensure that we cover things that you want to know. And as Dr. Praful said, we are open for feedback. So we are looking for your suggestions, how we can improve this program. This is purely a consumer-driven program. So what you need, you please ask us. We'll be happy to provide. And again, welcome to our experts here. All of them who will participate here are the kind of young Turks of India who are not only have achieved a lot in their young life in ophthalmology, but are also driven by a desire to know more and learn more. So they are the best to be the teachers that can help to mold you and understand and are aware of the problems that one faces at the present time trying to learn these subspecialties. So welcome everybody. It's absolutely a pleasure to have you all. And as I mentioned, we are open for feedback, whether it's positive or negative. We want to mold our teaching program so that it is useful to everybody. So Prabhu, please go ahead.
Dr. Pranita, you can take over from here, introduce the speakers and coordinator, then we'll start with the lecture.
Okay, sir. Okay, good evening, everyone. So I welcome you all to the first class of DOS Postgraduate Education Program. And it is my privilege to introduce our moderators for the Oculoplasty session, who are Dr. Pallavi Singh. She's trained from RP Center AIMS in Oculoplasty and has also done a surgical fellowship from the University of California. And currently she's in private practice in Ahmedabad. Our second coordinator is Dr. Puneet Jain. He's also trained from RP Center AIMS in Oculoplasty and is currently a consultant in charge of ophthalmic plastic surgery and ocular oncology services at Sharpsight Eye Hospital in Delhi, NCR. He's also done a long-term fellowship under Dr. Hunawar for oculoplasty and ocular oncology. And coming to our speaker for the day is Dr. Gunjan Saluja. She has done MD, DNB, FRCS, FICO, and FAICO in pediatric ophthalmology and strabismus. Currently, she is working as a consultant in strabismus, oculoplasty, and neuro-ophthalmology services at Bhatia Advanced Eye Care Center in Bhilai, Chhattisgarh. So with this brief introduction, we'll move on to the presentation of Dr. Gunjan.
Thank you, ma'am, for the introduction. Ma'am, may I please request you to share the presentation? Yes.
Yes, just give me a couple of minutes.
So as you can see, we have a very a group which is, as I mentioned, young but highly experienced with wide-ranging experience in multiple places. So they bring in one place their experience and understanding from different parts of not only the country but the world. So it's absolutely, I'm sure, look forward to a wonderful session, and we really look forward to having you all participate in the future sessions of the DOS PEP program.
Should I start the presentation?
Yes, Dr. Pranita, Dr. Gunjan, I believe is ready.
A very good evening, everyone. First of all, I would like to thank DOS for giving me this opportunity. And I'll be dealing with eyelid anatomy, embryology, and congenital abnormalities. To begin with the anatomy of eyelid, the eyelid can basically be divided into two parts, the anterior and the posterior lamellae, where the anterior lamella mainly consists of the skin and the orbicularis, and the posterior lamella mainly consists of the tarsus and the conjunctiva. Coming to the layers of eyelid, so eyelid has 7 layers, beginning from the skin, followed by the orbicularis. Then there is orbital septa. Beneath the septa is the fat. And then beneath that lies the LPS aponeurosis and molars. These are the retractors of the eyelid. And then the conjunctiva. So coming to the skin of the eyelid, it is the thinnest and there is no subcutaneous fat or the underlying tissues are very loosely attached. This results into the formation of a potential space. Coming to the orbicularis, beneath the skin is the orbicularis. Orbicularis is divided into two portions, the orbital and the palpebral parts, where the palpebral part further divides into the preseptal and pretarsal orbicularis. As the name is suggesting, pretarsal lies anterior to the tarsus and preseptal lies anterior to the orbital septa. Two important bony landmarks to be remembered in the entire anatomy of eyelid are medially anterior and posterior lacrimal crest and laterally the Whitnell's tubercle. So the anterior part of this pretarsal orbicularis forms the anterior crest of the medial canthal tendon and attaches to the frontonasal process of maxilla, whereas the posterior part of the medial side, it inserts into the posterior lacrimal crest and is known as the Horner's muscle. Laterally, the pretarsal portion is attached to the Whitnell's tubercle. Rheolin muscle is nothing but it is the pretarsal muscle at the lid margin and it helps in the formation of gray line. Coming to the second portion of the palpebral part of orbicularis, that is the preseptal portion. Laterally, this muscle forms the horizontal raphe, and medially, it inserts into the anterior crest of the medial canthal tendon. Jones muscle forms deep insertion of preseptal orbicularis. Coming to the next portion of the orbicularis, the orbital part of the orbicularis, it attaches medially to the medial canthal tendon, and laterally it forms an eclipse. So you saw that most of these structures were attaching to the medial canthal tendon itself, which is further attached to the lacrimal crest, and laterally everything is attached to the Whitnell's tubercle. Now, beneath the orbicularis lies the orbital septa. It is a thin, multi-layered fibrous tissue arising from the periosteum of the superior and inferior orbital rims. In the upper lid, it fuses with the LPS aponeurosis 2 to 5 mm above the superior tarsal border. So you can see here that in the upper lid, it is fusing with the LPS aponeurosis 2 to 5 millimeters above the tarsal bottom. And in the lower lid, it fuses with the capsulopalpebral fascia. Beneath the septa lies the orbital fat. So thinning of septa results into the herniation of the orbital fat. Now, you can see here that beneath the septa, there were orbital fat pads. In the upper lid, we have 2 fat pads, that is, the upper lid medial fat pad and upper lid central fat pad. And in the lower lid, there are 3 fat pads, lower lid medial, lower lid central, and lower lid lateral fat pad. Coming to the lid retractors. These are very important to keep your eyes open. Now, the lid retractors mainly consist of the levator palpebrae superioris and the molars muscle. Now, the levator palpebrae superioris, it originates just above the annulus of Zim from the periorbita of lesser wing of sphenoid. It then extends anteriorly for 40 millimeters and becomes tendinous at the Whitnell's ligament. Whitnell's ligament is basically a fascia which is extending from the medial to the lateral part of the orbit. So, medially, it is attached to the trochlea, and laterally, it attaches to the lacrimal gland. It acts as a fulcrum and is analogous to the Lockwood's ligament in the lower lid. Now, once levator turns into an aponeurosis, it gets attached in the form of medial horn, lateral horn, and downwards it's attached into anterior and posterior forms. So the medial horn attaches onto the posterior lacrimal crest, and the lateral horn, it is attached to the lateral tubercle. And downwards, levator divides into anterior and posterior parts, with the posterior part inserts into the lower half of the tarsus, and the anterior half, it forms the lid crease. It forms the facial slips to the orbicularis, and this results into the formation of lid crease. Beneath the levator is the molars muscle. It lies 12 to 14 mm above the tarsus and inserts at the superior border of the tarsus. So we can see here the molars muscle is there from the Whitnell's ligament and is attached to the superior border of the tarsus. It contributes to the eyelid elevation by 2 millimeters. Coming to the lower lid retractors. So lower lid retractor is mainly contributed by the capsulopalpebral fascia, which is analogous to the levator. It originates as capsulopalpebral head from the terminal fibers of the inferior rectus muscle. So here you can see is the inferior rectus, and then from the terminal fibers of the inferior rectus comes your capsulopalpebral head. The capsulopalpebral head then divides into two and encircles the inferior oblique. So here you can see is the inferior oblique muscle, and the capsulopalpebral head encircles it. Anterior to this inferior oblique, the two portions of the capsulopalpebral head join together to form the suspensory ligament of Rockwood. This fascia then extends into the inferior fornix and fuses with the tarsus and the orbital septa in the lower lid. Now, coming to the tarsus. So, tarsus is a dense plate of connective tissue and forms a major structural support to the lids. The upper tarsal plate measures around 10 to 12 millimeters and the lower measures around 4 millimeters. Its thickness is 1 millimeter and is attached to the periosteum through the canthal ligaments. So as I told you, everything is going to attach either directly into the canthal tendon or indirectly, but the structures remain the same. The attachments will be almost near that only. So located within the tarsus are meibomian glands, which are modified sebaceous gland. Now this medial canthal tendon, again, which is a major architectural framework of your lids, is a Y-shaped tendon. It originates as anterior and posterior head from the anterior and posterior lacrimal crest. It encircles the lacrimal sac and then splits into two to attach to the upper and the lower tarsal plate. So you can see here, it is originating from the anterior posterior lacrimal crest. It splits into two, encircles the lacrimal sac here, fuses, and then splits to attach to the upper and lower tarsal plate. The lateral canthal tendon attaches to the inner aspect of the lateral tubercle, which is there here in the inner aspect of the orbital rim. So this tubercle is the one which is giving attachments to almost everything in the orbit and the lids. So remember that this lateral canthal tendon, as you can see, is around a bit higher as compared to the medial canthal tendon. So this results into an upward slant. Coming to the eyelid margin. So eyelid margin basically is the confluence of the cutaneous stratified squamous epithelium, the edge of the pretarsal orbicularis, and the conjunctival mucosa. Gray line is the section of pretarsal orbicularis, that is the muscle of Rheolin, lying anterior to the tarsus. Meibomian glands open just in front of the posterior border, as you can see. So this is the anterior border, this is the posterior border, and meibomian glands are lying here, just anterior to the posterior border, or just in front of the posterior border of the lid. Coming to the meibomian glands, so there are around 25 meibomian glands in the upper lid, which are slightly more, and 20 around in the lower lid. Eyelashes originates in the anterior aspect of the lid margin, just anterior to the tarsal plate. So here this is the tarsal plate, and just anterior to the tarsal plate lies the eyelashes, as you can see, and they're arranged in 2 to 3 rows. Now the glands of the eyelid include the glands of Zeiss, gland of Mole, and the meibomian glands. We have already talked about the meibomian glands, which are basically opening just in front of the posterior border. And if you talk about the other two glands, the glands of Zeiss are nothing but they are modified sebaceous gland, and they open at the base of the hair follicles. If you look here, the gland of Mole, they are modified sweat glands, and they are also opening in a row near the base of the eyelashes. So we can see here, these are the eyelashes, and it is somewhere near the base of these eyelashes that the glands of moles are present. And glands of Zeiss, they lie at the base of these eyelashes. Now, the arterial supply of the eyelids is mainly from the two sources. It is one of the structures which is receiving the blood supply from both the branches of internal carotid artery as well as from the external carotid artery. So one of the area where there is anastomosis of both the systems. Internal carotid artery, it is through the ophthalmic artery and the branches, that is supraorbital and lacrimal artery, which contributes to the arterial supply. And the external carotid artery through the arteries of face, angular artery, and temporal artery are the branches which are contributed by the external carotid artery. Now, these two systems, they anastomose and they result into the formation of the arcade. So there are two arcade, the marginal arcade and the peripheral arcade, where the marginal arcade is lying anterior to the tarsus near the follicles, and the peripheral arcades lie superior to the tarsus between the LPS and the molars. Coming to the venous drainage, so the pretarsal tissue, it drains into angular vein medially and superficial temporal vein in the lateral part. The posttarsal tissue drains into anterior facial veins and deeper facial branches of the deeper branches of the anterior facial vein, orbital veins, and the pterygoid plexus. Coming to the lymphatic drainage, so the lymphatic drainage is basically, if you look here, that is medial 1/3 of the upper lid and medial 2/3 of the lower lid. They are going to drain into the submandibular node, and medial 2/3, lateral 2/3 of the upper lid and lateral 1/3 of the lower lid, they are going to drain into the preauricular nodes. So I think this is clear that medial 1/3 of the upper lid and medial 2/3 of the lower lid, it drains into submandibular lymph nodes, and lateral 2/3 of the upper lid and lateral 1/3 of the lower lid, they drain into the preauricular nodes. Now the nerve supply to the lids is by different nerves. So LPS is supplied by the third cranial nerve, seventh nerve supplies orbicularis, and molars is supplied by the sympathetic nerve. The sensory supply is by the trigeminal nerve branches, the ophthalmic division to the upper lid, and maxillary division to the lower lid. Coming to the embryology of the eyelid. So eyelid formation takes place in these following steps. So first there is lid fold formation, followed by fusion of these folds. Then the eyelid development takes place, followed by their separation and maturation of the eyelid structures. So it is at around 37 days that two grooves form above and below the eyes. That is the rudimentary eye which is being formed. And you can see here that two grooves are formed, and these two grooves then form the eyelid fold. These eyelid folds further mature to form the eyelids. The upper fold is formed by an extension of the frontonasal process, and the lower is formed by the maxillary process. The lids diffuse temporarily by the movement of the periderm cells, and once there is fusion of the lids, the upper lid structures, they develop faster, and LPS develops at around 2.5 months of gestation and separate from the superior rectus at 4th month. It is at around 28 weeks that both the lids, they separate. So we can see here that first there is fusion of the lids, followed by maturation of the structures, followed by the separation of the eyelids, which takes place as the term progresses. Now coming to specific development of various structures of the eyelid, mesoderm gives rise to the fibers of the striated muscles, endothelial lining of blood vessels, Surface ectoderm gives rise to the skin epithelium, hair follicles, lice glands of mole, meibomian glands. Neural crystals forms the tarsal plate and supporting architecture, levator aponeurosis, Muller's muscle, orbital septa, all are contributed by the neural crystals. Now, congenital anomalies of the eyelid results from defect in any of these stages of the eyelid development. So first is if there is failure of formation of the eyelid folds. That results into a rare abnormality that is known as ablepharon, where there is total absence of the eyelid, as we can see in this picture. And it, as I told, that it results because of the failure of lid fold development and neural crystal migration. The syndrome associated is the ablepharon macrostomia syndrome. Cryptophthalmos results from the failure of development of palpebral aperture, and there is a continuous skin which is extending from the forehead to the cheek. In rudimentary forms, incomplete lids may be seen, and underlying globe is usually microphthalmic. Associated syndrome is Fraser's syndrome, where cryptophthalmos is associated with syndactyly. Now, coloboma of eyelids are partial or full thickness defects which are triangle in shape, where the base lies towards the margin, and upper lid colobomas are usually seen at the junction of medial 1/3 and lateral 2/3 and are commonly associated with golden hair syndrome. Lower lid coloboma, on the contrary, are usually seen at the junction of lateral 1/3 and medial 2/3 and is associated with the Treacher-Collins syndrome, associated with the short, slopy palpebral fissure, hyperthalamic orbits, and defective lateral margins. When associated with the cleft palate, there can be an associated difficult swallowing also. Now, the other syndromes which are associated includes the Char syndrome, which includes the coloboma, heart defects, spinal atresia, growth retardation, genital abnormalities, and ear abnormalities, and Fraser's syndrome associated with cryptophthalmos and syndactyly. The Manitoba syndrome is associated with the lid colobomas, cryptophthalmos, and triangular growth of hair extending from scalp to eyebrow, bifid nose, and anal atresia. The management depends upon the size and location. If it is small, you can simply close by canthotomy. If it is medium size, then you need to make a flap. And if it is large, then lid sharing procedures are preferred. Ankyloblepharon are partial or complete adhesions between the superior and inferior eyelids and are characterized by the fine strands of tissue connecting upper and lower lids. Epiblepharon is presence of a rudimentary skin fold, and there is an excessive skin fold which is going to cause the same. It attenuates in the down gaze, and most of the times it resolves spontaneously. However, if there are lashes rubbing to the cornea, you need to have an intervention. Congenital entropion results from the disinsertion of the lower lid retractors. There is no extra skin fold here, but there is inward turning of the lid margins. Everting sutures and HOTS procedures are the surgical options. Congenital ectropion results from shortening of the anterior and posterior lamella and requires skin grafting. Epicanthal folds are skin folds in the medial canthal area, and they can be epicanthus superciliaris, that is from above the brow to the lateral aspect of the nose. Okay, so from above the brow to the lateral aspect of nose. Epicanthus tarsalis from the lateral side of upper lid to medial canthus. Epicanthus palpebralis, which is equally distributed between the upper and the lower lid. Epicanthus inversus, which is originating from the lower lid and extending to the medial canthus. Surgical management here includes doing a Yvplasty, Mustardis, double Z plasty. Congenital ptosis is caused because of the LPS infiltration by fibrofatty tissue. Lid lag, poor LPS action, faint or absent lid crease are its characteristic feature. Requires early intervention in cases of anisometropic amblyopia. Depending upon the LPS action, one can either plan LPS resection or a sling surgery. BPES syndrome has ptosis associated with blepharophimosis, epicanthus inversus, and telecanthus. It is of two types, the type 1, which is associated with female infertility, and type 2, which is also autosomal dominant but not associated with infertility. Uriblepharon is caused because of the outward and downward displacement of the lateral canthus. And as I told that the normal position of the lateral canthal tendon, it is above slightly, and craniofacial abnormalities are associated with the same. Telecanthus is characterized by an increased distance between the inner canthi. Here, the intercanthal distance is increased, but the interpupillary distance remains normal. So it is basically the lateral displacement of the canthal tendons, causing an increase in the intercanthal distance. In hypertelorism, there is increased distance between the two medial orbital wall, causing an increase in the intercanthal distance as well as in the increase in the interpupillary distance also. Dystopia canthorum is a type of telecanthus which is specifically seen in type 1 Waardenburg syndrome and is characterized by the lateral displacement of the lacrimal punctum. So this is the difference between the telecanthus and hypertelorism, and I hope now it is clear. So that was all for the anatomy and congenital abnormalities of the lid and development of eyelid. Once again, thank you for the opportunity.
Thank you, Dr. Gunjan, for that comprehensive class on the topic of anatomy, and that is the base for every specialty that we deal with. So with that, I will hand over the mic to our moderators, Dr. Pallavi and Dr. Puneet. Are there any questions that you want to ask Dr. Gunjan?
Okay, so I think we have a few questions from the audience, and I would encourage all of the people who are tuned in. If you have any doubts in what we went through, I would encourage you to put that your questions in the chat box here so we can ask them. So one of the questions Gunjan, Dr. Priyansh Agarwal has asked, how to differentiate between congenital entropion and an epicanthal fold?
Yes, so see, a congenital entropion, as the name is suggesting, it's an entropion. So there will be an invert turning of the lid margin. Means you will not be able to see the lid margin structures like the meibomian glands, which will be displaced inwards. Whereas an epicanthal fold basically is an extra skin fold which is present in the medial canthal region. So these two are very different things. You might have asked what is the difference between congenital entropion and epiblepharon, wherein epiblepharon you find entropion, there is an inward turning of the eyelid margin. So that's the difference between the two things.
I think one of the things that we talk about is that like an epiblepharon is common in what you call the Eastern Asian anatomy. You see a lot of kids, even if they're from the Northeast, or if you see Eastern Asian kids, the epiblepharon is quite common. But I think that one of the things that also differentiates it, and Gunjan, please correct me if I'm wrong, is that as you grow, children usually tend to grow out of the epiblepharon. So you don't just operate. That's not an indication for surgery as soon as you see it.
So,
Entropion, you'll probably need to operate at some point.
So most of the times, epiblepharon, it is going to have a self-resolving course. It will have a self-resolve. It will self-resolve by itself. But sometimes, if there is rubbing of the cornea with the eyelashes, you need to operate them early. And the surgery is also quite simple for the same. But just beware of the ectropion. Do not cut the excess skin too much.
All right, so we have another question. Dr. Sankla Anita is asking, can you please explain, I think dyscanthorrhum is what she's written. You were speaking about the Waardenburg syndrome. So
Yes.
can you just
So
explain?
basically, dystopia canthorum is a type of telecanthus which is specifically found in Waardenburg syndrome. Waardenburg syndrome has a lot of other features also, including a white full lock of hair, heterochromia iridis, and dystopia canthorum is one of the feature of the same, where you find that there is an increase in the intercanthal distance, as well as there is a lateral displacement of the lacrimal punctum. So when you draw a line, as you can see, I had put the picture also. If you draw the line,
Why don't you
passing
share
through
the
the,
picture again, Gunjan, if you have the PowerPoint
actually I've logged in from my cell
from
phone, so
that's okay.
I don't have my presentation here. So basically, if you draw a line from the medial 1/3 of the lid, you will find that the lacrimal puncta it is displaced a bit laterally. So that was very evident from the picture also. What else? Do they want to ask something specific about it?
No, I think they just wanted you to explain dystopia canthorum again, and I think we've
So
done that.
basically, it is a type of telecanthus specific feature of Waardenburg. That's it. With lateral displacement of the lacrimal puncta. That's the specific thing.
We got it, ma'am, also. So I think you explained it really well. All the rest, I mean, everyone who's attending, anything else, this is the right time to get all your questions answered. We have the wizard of anatomy with us, Dr. Gunjan. Is really, I mean, she's probably one of the best teachers you can get for anatomy. So feel free to ask your questions here. If not, there's a YouTube link. You can always leave your comments, and we will try to answer those in the comment section and everything. But if any other questions here, we would be happy to answer them.
I think we had
sometimes we get lost in technical terms. It is more important to understand the concepts. So like Gunjan said that for all practical purposes, the term is just telecanthus. That term is just telecanthus specific to a syndrome. So stick to the basics. It's a very well presented session and lots to take away. And I think a lot of short questions and all those things can also be answered. Gunjan really explained it very well. I think it's very well done.
Thank you, Gunjan, for that extensive lecture, and thank you, Dr. Pallavi and Dr. Puneet, for being with us. So with that, we come to an end to our first class of DOS Postgraduate Education Program. And we'll be having classes every Monday and Thursday, as you're aware. And the details of the class must have already reached you in your inboxes. And the next class we'll be having Dr. Pallavi, would you like to introduce the next class? So the next class is basically on the workup of eyelid of cases of oculoplastic cases. And the presentation is by Dr. Pallavi.
Akriti Desai.
Dr. Akriti Desai. Yeah, so the next lecture is by Dr. Akriti Desai, and she'll be talking about how to work up an oculoplastic case and diseases of eyelid disorders. So looking forward to your active participation in the next class as well. And we'll have classes every Monday and Thursday at 7:30 p.m. And the link for the classes will be coming on to your inboxes, in your email inboxes. So keep a track of the same. So thank you everyone for your presence, and good night.
And just a reminder to everyone that for people who could not register, the YouTube link is available, and you can always, sort of have your questions over there. And so make sure to please spread the word amongst your friends and send them the YouTube link, because I think you cannot register for
We can further register. We can register further after the class is over. The registration link will reopen, and you can register further for the next classes.
Excellent. All right. So please spread the word. And like Dr. Pranita said, How to Work Up an Eyelid Disorder by Dr. Akruti on the 8th of August, 7:30 p.m.
Okay. So